Hey there, it's time to take the lead. Trust your voice, know what you need. Let's break it down.
Welcome to Beyond Clinical Walls with your host, Dr. Bayo.
We'll claim your life.
Picture this. It's 2 a.m. and you wake up with crushing chest pain. Your mind races. Is this a heart attack or just heartburn from last night's pizza? You're torn between not wanting to overreact and potentially ignoring something serious. Or maybe it's your child with a high fever that won't break and you're staring at the clock wondering if you should wait until morning or head to the emergency room now. And your mom's voice echoes in your head, don't mess around with your health. Then you remember that horror story of your coworker who told you about waiting 6 hours in the ER, only to be told it wasn't an emergency. You want to make the right decision about your health, but navigating emergency care feels like solving a puzzle blindfolded. Sound familiar? With so much confusion about when to go, what to expect, and how to navigate the system, it can be hard to know how to get the care you need without the stress and the surprise bills. That's why I'm so excited to have this conversation today. The emergency room doesn't have to be a source of anxiety because when you understand how it works, it can help you make informed decisions and advocate for yourself. That's why I'm excited to have my amazing friend and expert, Dr. JMack Slaughter.
Hello.
Hello. I'm so happy to have you. He is an emergency medicine physician who's become a trusted voice to over 1 million followers online. But his journey is anything but typical. He once toured the country in a boy band and appeared in the film Fat Albert before dedicating his life to medicine. Dr. Slaughter beautifully combines his passions through his nonprofit Music Meets Medicine, which has raised over $500,000 for music therapy at Children's Hospital and helped generate $2 million for cancer research. As a practicing ER doctor in Texas with over 300 million views online, he brings both clinical expertise, genuine warmth to make healthcare accessible and understandable for everyone. Dr. JMack, welcome to the show.
Hey, good to be here. Thanks for having me.
It is so good to be here. So for context for anyone listening right now, the energy that we can feel each other online as we have this is just so palpable because I just truly adore you. I adore your mission, your love, your energy.
Right back at you. You're such a positive human being. You're so engaged in so many things. You're truly affecting other people's lives in wonderful ways. And I feed off of that.
Well, I feed off of you as well. So I'm so excited to have you here. We are going to start with something heavy. So if you're game for some, heavy rapid fire questions.
Let's go.
Let's do it. Where did you originally grow up?
It's so heavy. I can't answer that. I grew up in Fort Worth, Texas, where I currently live. I left for a little while. I chased dreams. I achieved some form of that dream and ultimately decided to come back to my hometown and become a doctor.
I love it. So what is the most common thing people come to the ER that could have possibly been handled somewhere else?
High blood pressure. When people think about high blood pressure in your brain and emotionally speaking as well, when it gets above a certain level, it feels like an emergency. And it may be an emergency. It may be an emergency, but there's a difference between something called a hypertensive emergency, which is when your blood pressure is extremely high and it's damaging your body, it's damaging your organs, and something else called hypertensive urgency, where it's an extremely high blood pressure, but it is not actually doing significant damage to your organs. Now, we don't want blood pressure to be riding high on a regular basis. We absolutely know that that is a big risk factor for heart attacks and strokes and all sorts of bad things down the line. But if temporarily the blood pressure is high, even when it's over 180 systolic or over 95 systolic, 100 systolic, that's a very scary level. But if you're not having a headache, you're not having vision changes, you don't have any chest pain, difficulty breathing, any major symptoms, then that's actually something that you may be able to call your primary care doctor or whoever's on call for them and have a discussion about it. Do you have a medicine that's already prescribed to you to take for blood pressure? You may be able to take a second one. Don't just take a random one and think that that's the way to do it. Your physician or your provider should be making that decision with you, but the blood pressure alone is not an emergency. It's when you have the combination of that high blood pressure plus symptoms.
What is your go-to? I already know this answer, your go-to drink during an emergency shift.
My go-to drink during an emergency shift is actually just water, but it depends on the time of day. If it's an early morning shift, I like to intermittent fast. And so I keep myself from, wanting to eat by just having black coffee. I have black coffee with no cream, no sugar. There's 0 calories in it. And so it doesn't break my fast. So if I ate at 6 or 7 p.m. at night, I can push through until sometimes noon and feel totally fine, feel very mentally alert. And part of the reason why I'm able to do that is because I have a couple of cups of black coffee, and I'll even have a cup of decaf coffee sometimes too. It's a natural appetite suppressant. It helps with wakefulness. I'm as present as I need to be in the emergency department, but I don't break that fast.
What is the biggest myth that you hear about the emergency room?
You know what? Honestly, it's that the doctors didn't care or the nurses didn't care. In the ER, we are constantly inundated with chaos, stimulation, tragedy. We give a lot of bad news to a lot of good people, and that can wear on your soul. But despite the fact that we may look like we don't care about patients individually, because again, we may be numb, we may be tired, we may be exhausted. Every single one of us got into medicine because we wanted to help people. And we're there because we truly want what's best for our patients. I think that there are very few people who work in healthcare that truly do not want to do what's best for their patients. And so emergency workers care just as deeply as primary care doctors, as surgeons, as OBGYNs, as pediatricians, but sometimes it may not look like it on our face because we might just be so exhausted and burnt out.
I second that. So what was the inspiration behind Music Meets Medicine?
Oh man, so many rewarding things about the nonprofit. The inspiration for the nonprofit is actually so first of all, I grew up in a family band. I grew up performing with my 2 older sisters and my dad on stage. And my mom was a brilliant percussionist, but she got too much stage fright, so she didn't perform on stage with us. She was like the band manager and like ran sound and stuff like that. But we grew up playing and singing our whole lives. Literally I was 3 years old when I got put on stage. And then, flash forward, I've been in this boy band and I got to be in this like TV show and this movie and stuff. And then I decided to go to become a doctor. And when I was a pre-med, my mom was diagnosed with cancer. She was diagnosed with stage 3 breast cancer and surgery, chemo, radiation. She ended up, she had a lot of complications, but ultimately her first chemo session, my sisters and I are watching as my mom undergoes this prophylactic treatment. So basically, when you get one certain type of chemotherapy, it increases the risk of turning your fingernails and your toenails black and having them fall off. And my mother has already had the removal of both of her breasts, and we shaved her hair off. And so much of her femininity felt lost, and her fingernails and her toenails, to her, that was the last of her femininity that was about to go out the window, unless she put her fingers and toes in ice, because ice constricts the blood vessels. It's called vasoconstriction, right? You know that, but for your listeners, if you don't know, it causes vasoconstriction. So when the toxic chemicals are floating through the bloodstream, they have a much lower likelihood of reaching those fingernails and toenails. And so this whole hour that my mom's receiving this chemo treatment, she has her fingers and toes in ice. And if you remember being a kid and you hit your head and you have ice on your head for like 2 minutes, you're like, oh my gosh, get this thing off of me. But she just has so much willpower that my sisters and I are just watching her struggle. And she's already nauseous and she's been throwing up. And now her fingers are just like burning, but she won't take her fingers. So this hour becomes one of the longest hours of my entire life to watch as like previously pretty self-centered, like 22-year-old kid or whatever. Right. And I'm like, clearly, like we have to do something has to change. And so the next chemo session, my sisters and I did what we always did together as kids. And we brought our instruments and we started playing and we started singing for her. And she was like making requests from when we were like 5 years old on stage together and singing and dancing. And the room had so much joy. There was so much joy and love and happiness in that room. And it was one of the most powerful things I've ever experienced in my entire life. This is before music therapy was really a thing in the hospitals, because I'm that old. This was like 20 something years ago. And people from the other rooms would kind of wheel by and be like, can you come over to room 425 next? And we're like, sure. And so we went in there and played for them also. And after I felt that power, I was like, I have to do something with this. It would feel selfish to keep that experience to myself, you know? And so I started a nonprofit. And at this point, as you mentioned, we've raised over $500,000 for music therapy. We put a jam room at Dallas Children's Hospital. There's a jam room that kids can go into and play the drums and play guitar and just experiment, you know, and put on headphones so other people might not hear how not awesome it sounds if it's their first time. So we call it like embarrassment-free exploration. And so I don't know, it's just been a beautiful thing to be a part of, and to take something from a trauma that I was experiencing in my life and to be able to take that and turn it into something positive that, you know, benefits others is one of the most valuable things that you can do with pain.
It is absolutely beautiful. And for someone who is a music lover, I believe music
incredible
is
dancer.
Oh, thank you.
If people don't know, this girl can dance.
Thank you. I do love to dance. And music is so powerful. It is one of the underutilized tools that should be everywhere. And it can be prescriptive to you. And I'll just say, even in medicine, it can be so powerful. I've written prescriptions to my patients to listen to their favorite song.
Woo, I love it. I love it. Get out the prescription pad.
Yes, because it's huge. It can make a huge difference. And I love the work that you have done. I love the story behind it and how you have continued to truly make waves in different ways of helping people through music. And that is therapeutic. Music is medicine.
The best part about nonprofits is that when they're done right, everybody wins. You know, the target audience, whoever the beneficiaries of the nonprofit are, they can have a big positive benefit to it. The people who started it and who are trying to run, like, you think that it's a selfless act, and in many ways it is, but it's also selfish. I get so much out of it. It fills my freaking heart. It gives me so much purpose. It makes me a happier person and probably a better dad and better husband and better neighbor. You know what I mean? And then the donors know that they are enabling something that otherwise would not be possible. And so if nonprofits are done right, everybody wins.
When you say that, it makes me think of my father's words. He would always tell me, Bayo, when you help others, you're helping yourself.
Oh, yeah.
And it's true, you know, putting that effort towards whatever it is, you are. And it is as selfish, but it's a rewarding and it's a good thing to do. So
I put that in the song, a song that I wrote for my daughter, actually. The lyric is, every day you give, you will be receiving. You know, it's like, and it sounds, again, I don't want it to sound selfish, but it's true. You do, you give, and the universe finds a way to give it back, you know, and it's just, everybody is uplifted by it.
I love this. I love it. Well, this is a great shift into, when it comes to medicine and music, how you have not only incorporated your background into the medicine you do today. I believe it's part of your spirit and how you treat patients every day. So let's just start with the basics first, just to kind of lay the land. What should people do when it comes to the emergency room? Because we started the show off talking about how it can be just overwhelming and intimidating. So let's talk about the emergency room and include, how do you know if you should go to the ER or the urgent care?
Man, that's a hard answer. There's a lot of nuance there. But in general, all chest pains need to go to the ER. It's hard because sometimes, you know, you may be like, well, you know, I don't drink, I don't smoke, I don't have high blood pressure, I don't have high cholesterol, I'm only 30 something. And I'm having this severe chest pain, maybe I can just ignore it for a couple of days. But here's the thing, not everything is a heart attack. You can have a popped lung, you can have a severe pneumonia, you could have a lot of fluid around your lung, you could have a blood clot in your lungs, you could have a heart attack. There are just so many things. There's just like a huge list that no one anywhere else can rule out except the ER, because you need to have a rapid turnaround in testing. And sometimes patients feel like they're at the ER for a long time and nothing happens, because it can take hours to get all your labs and your CTs back, 2, 3, even 4 hours sometimes. And they're like, what have you guys been doing? But when you think about what actually happens in an outpatient setting, you draw blood work, you send it off to a lab, you get the results in like 2 days, 3 days. And in the ER, whether it's 1 p.m. or 1 a.m., you're going to get those results back extremely quickly. Same thing with CT scans. Sometimes it's weeks until you can get in to do a CT or an ultrasound or an MRI or something like that. And so just knowing that even though it feels like not much is happening, there is a lot that happens in the ER, I think is an important mentality to have when you're there. And also there are a lot of other people, and you don't know how sick they are too, because your ER doctor may have literally just brought someone back from the dead. Maybe their heart was stopped and they were able to get pulses back. And then we do that. We stabilize them the best we can. And then, make a phone call, and then we run into the next room and they're like, tell me about your cough, And so it's just that the ER is a really crazy, chaotic place. So it's important to have that in your head when you go to the ER. Other things that you should go to the ER for: severe abdominal pain. There are just too many emergencies inside the abdomen that you cannot, unfortunately, rule out in urgent care or a primary care setting. So severe abdominal pain, I say 10 out of 10 times needs to go to the emergency room. Sometimes very minor fractures can go to urgent care if it's just a finger or a toe, or it doesn't seem serious. Maybe if the urgent care has x-ray capabilities, that could be a place that you could go. But most of the time, if you have a long bone fracture, if you have just severe pain in your arm, especially if the bones are like pointing in different directions, same thing with your ankle, etc., you're probably going to need to go to the ER. We may need to help put the bones back in place, but putting you to sleep as we do that, or something called conscious sedation, straightening those bones out, talking to the orthopedic doctor and making sure that they're okay with you coming to clinic later on. So long bone fractures are a big one. Man, bleeding, if you're having bleeding when you're going number 2, or you're throwing up blood, or you're coughing up blood, it's hard for that to be managed anywhere outside of an ER2. So, and same thing with lacerations. If it's uncontrolled bleeding, sometimes an urgent care can take care of it. But if it's a real deep, big, nasty one, probably needs to go to the ER2. So it's hard to be comprehensive when it comes to what should all go to the ER. But just know those are some good rules of thumb, at least, to follow.
Well, you dropped so many gems. There's a couple of things that I want to highlight. First, I often talk about online how doctors have differential diagnosis. I like to call it a running list. And you highlighted the fact that if you have chest pain, there could be so many different things that could be connected to it. So being in the right place can help make sure that we can either rule in, as you and I know, or rule out what could be due to that. The other thing that I think is an important piece that you mentioned is wherever you go, you want to make sure they have the resources, because if you have, let's say it's chest pain and it is a heart attack, an MI, you need to make sure that that facility can do the appropriate workup. So let's talk about a patient who has chest pain, as I talked about in the opening of the show. Let's walk the listeners through. You have chest pain. You've just arrived in the ER. What should they expect?
The first thing that the staff are going to do when they hear the words chest pain, they're going to pull you back and they're going to get you to an EKG machine as fast as possible. That's an electrocardiogram, and it basically looks at the electricity of your heart. And the first thing we need to do is make sure this isn't a massive heart attack that immediately needs to go to what's called the cath lab, where the heart doctors can potentially open up the blood vessels to your heart and restore blood flow to the heart, which that's what a heart attack is. The heart is not getting enough blood supply back to itself to properly function, and potentially that tissue can die, right? And so we get you back, do an EKG of your heart. It may look normal. That doesn't mean you're not having a heart attack, but it does mean that you're not having what's called an ST elevation MI or a STEMI, which is the one that has to go right now. Every minute counts in restoring that blood flow. If the EKG looks good enough, you may end up getting some blood drawn, and you may sit back in the waiting room, or you may sit in the waiting room before you get blood drawn, depending on how things function in that emergency department. So those are the first things that you should experience. After that, the doctor's going to ask you questions about whether you have risk factors for a blood clot, whether they should be worried about that, do some testing for that, perhaps that we have blood tests to do that. If those blood tests are positive, we do CAT scans, or if we have a high enough suspicion, we just go right to the CAT scan. We're definitely going to do x-rays to look at your lung. Do you have something called a pneumothorax or a popped lung? Is there fluid outside of your lung? Do you have a pneumonia? Is your heart enlarged? Do we need to worry that, you have something called like heart failure and your heart isn't able to do a good job pumping things around? Are there fluid on there? There's so many things that we're looking at. But blood work, the EKG, the electricity of your heart, and imaging are the three mainstays of evaluation for chest pain.
So you've just shared all the things that you're looking into, and it's helpful for listeners to realize, because sometimes you're sitting there in that room and you're like, everybody's doing things, everybody's walking around, but no one's helping me. I've been here for 4 or 5 hours. Can you paint a picture of what is actually happening? So you've got the patient who has chest pain. We just talked about all the things that you want to rule out. What else is happening beyond that patient?
The best way that I can illustrate it is to have you watch The Pit, because The Pit is the best ER show that has ever been created. It is so close to what it's actually like to work in an emergency department, although not all ERs are that crazy. You know what I mean? They gave you like the most intense of the most intense all in one shift. And sometimes it's actually like that, where you're dealing with all of these crazy emergencies and all these crazy kind of more rare procedures all in the same shift. That happens, but that's not my everyday, and that's not most ER doctors' everyday. But what you do deal with, whether it's the really rare things, the really severe things, or it's kind of, somewhere in between minor and really severe and rare, you'll end up seeing a lot of different patients for a multitude of complaints. So at the same time that blood work is being drawn by the nurses and the radiology techs are coming to get you and take you to x-ray, not only are those nurses and radiology techs doing that to a bunch of other patients simultaneously, but that doctor is doing the same thing, going from room to room, trying to update people, trying to refine that process. You mentioned the differential diagnosis. There's a broad list of things that could be going on today. Some of them very serious, some of them not so serious, some of them incredibly rare. And our job is to systematically rule those things out and land as close to we can as a diagnosis. But here's the other hard thing about the ER. Sometimes we don't get the diagnosis. And as ER doctors and nurses and providers, we also have to be okay with that, because we can't diagnose everything. If we diagnosed everything in the emergency department, somebody with a heart attack or a stroke or an acute surgical issue in their abdomen could be dying in the waiting room. So our main job is to figure out, is this an emergency or is it not? Big branch point. If it's not an emergency, if it is an emergency, get them where they need to go. Are they getting admitted? Are they going to surgery? Are they having a procedure, right? If it's not an emergency, do they have to get admitted? Are you safe to go home? And sometimes we find ourselves in the position where the workup was normal in the ER. And we don't mean that there's nothing wrong with you. We don't mean that you're making up your symptoms. But if the ER doctor did a good job and ruled out all of those life-threatening emergencies, you may go home with a different type of doctor to follow up with, like a cardiologist or a heart doctor, or a pulmonologist or a lung doctor, or a rheumatologist, or just the primary care doctor. But once the ER doctor has effectively done their job and teased out those different things, then we may or may not have the answer. And that's unfortunately something that we all kind of have to figure out how to live with.
Well, I'll see patients in my clinic. Let's say they went to the ER for chest pain and then they're doing a follow-up with me. And I'll say, I'm going to go over the notes. I'm looking at everything. And they're like, well, you don't really need to look at anything, Dr. Bayo, because they didn't do anything for me. And it's often they don't understand you are ruling out to make sure that it isn't anything of emergent, right, that they do not need to be admitted to the hospital. So sharing, your job really is to make sure it's not the worst of the worst. And if it isn't, the plan is to follow up with your primary or your specialist. And I think that is often left, especially when that patient is sitting there, they're going to be discharged. They feel like they don't have a diagnosis, but what you do have is a diagnosis that nothing is emergent doesn't mean it's not important.
Yeah. The flip side of that too is that you almost don't want the ER doctor to be doing a lot for you, because if the ER is doing lots of procedures and calling a bunch of specialists about you emergently, that means there's something very, very serious going on. And that's kind of the interesting thing about patient satisfaction. And that's just like a whole story that we can go into, we talk about that for hours. But a lot of times they actually only end up interviewing the patients that get discharged home. So the only people that are giving feedback to whether the ER doctor did a good job or not are the people that did not have an emergent condition and got to go home safely with antibiotics, pain medicine, et cetera, et cetera. But the people who you had to actually like do an intense procedure like a central line where you put this like big needle in somebody's neck, or you're intubating them, you're putting a breathing tube down their throat, or they have severe sepsis and you're giving them antibiotics and fluids and this and that. Those people don't get interviewed. So the people's lives who you actually like truly save, they never ask them, what do you think about that ER doctor? Did you have a good experience? Those people be like, yeah, that doctor saved my life. They never asked that guy. Isn't that crazy to you?
That's a great point to make.
It's crazy to me.
It's unbelievable because you're right. It is those that are discharged because they're discharged and then 2 to 3 days later, they get that follow-up call. But the patient who you did everything, you are intubating them, you're doing everything, they're still in the hospital. They're not answering that call.
And some doctors will
left.
like almost get like fined by their partners if they don't have high enough like Press Ganey scores. You'll like, and you're like, I'm just doing my best, you know, I truly am doing my best. But
right, by ruling who is emergent and who isn't, and making sure those who need that care in that moment have it.
And when you are that person who has that true emergency, the ER is like the most incredible place on the planet because everything stops. All of the multiple ER doctors, half of your nursing staff, you know, respiratory therapists, everybody rushes to your aid simultaneously. Like you'll never see a faster, more efficient, more effective mobilization of healthcare workers than in a true emergency in an emergency department.
I agree. It is a beautiful dance to watch what happens. I mean, it is coordinated. You don't even have to speak to each other. Everybody knows what they're thinking, you know, what's going to happen next. It's beautiful.
Yeah,
So
totally.
I second that. It is fantastic. Well, here's a reality check. According to the Agency for Healthcare Research and Quality, the average emergency room visit costs $750, and that was back in 2021. Now, costs have only gone up since then. With that kind of price tag, people deserve to know what they have control over and what rights they have as a patient. Dr. JMack, can you help us understand how patients can be informed about their costs while they're in the ER?
I think the most important thing that you can do while you're in the ER is a little bit more difficult because prices, because of the nature of how billing works in medicine, it happens after the fact. Do you have insurance? Do you not? Prices are different based on so many factors that are outside of the control of the physician, the nurse, and many times the hospital itself. And there are all of these things that contribute to what the actual price ends up being. But you can absolutely, and you should, ask the registration professionals. There are people whose job it is to check your insurance, see what kind of deductible you have, make sure you're in network at this facility, et cetera, et cetera. They should be able to give you some sort of ballpark estimate of what this visit could actually cost. So that's an important first step, and that's during the visit.
I agree. That is so important. And a lot of people aren't aware of that. Also, a lot of people aren't aware of, as patients, that they do have rights of what they want to consent to and what they don't want to in the emergency room. So what kind of control, can you give examples of what they do have when it comes to their care?
You have 100% control over your care. I think that's a very, very important thing to know, that although there are a lot of people with a lot of experience and credentials behind their name, the person in control in the ER is always the patient, unless they're a threat to themselves or others, right? Or they do not have what's called decision-making capacity, meaning if you're extremely inebriated or you're on drugs or you have severe dementia and you cannot make medical decisions for yourself, then the ER staff or your family members will need to make those decisions for you. But outside of those exceptions, those very few exceptions, you are in control. Super important that you know that. And so if there's certain tests that you don't understand, please ask the provider. If they aren't they should be very willing to discuss those with you. If they aren't, who cares if they give you a grimace? If they seem busy, whatever, this is your body. This is, you are in control. ask them about those tests. Why are we doing these tests? What are we ruling out? And they're going to have an answer for everyone. They should not be ordering tests they don't have a reason for ordering. So they should absolutely have answers for every single order that they have. If there's something that you're uncomfortable with, I think it's really important to advocate for yourself, but also to make sure that it's a two-way discussion, right? The person in control is the patient, 100%. But there needs to be a well-informed, discussion that happens between the provider and the patient about why we should or why we shouldn't do certain things. And so I think it's very important that while you advocate for yourself, you have an open mind, even though you might have talked to someone who told you something about this condition or this procedure, or you maybe read something online, Google, ChatGPT, etc. I think it's very important that you speak about your concerns, but you also listen to why the doctor, who has anywhere from 1 to 40 years experience dealing with these same complaints on a daily basis, why they do want to do that test or procedure. I think that's a very important conversation to have.
Exactly. It is bidirectional, and it's important that there is the ability to foster mutual respect on both sides, where the doctor is sharing where they're coming from and the patient is allowed to share where they're coming from. And there isn't this level of dismissal or feeling gaslit.
If the doctor says, you're going to do this because I said so, get a new doctor. You can get a new doctor in the ER just like you can get a new doctor in a primary care office. The likelihood that there is another doctor that's immediately ready to see you is lower. But if you get somebody that just says, like, you're going to get this test because I say you're getting this test, that is not the doctor for you.
I agree. And, I often give phrases that people can use when they're talking to their doctor, but I would love, do you have any phrases or anything that you would feel very receptive to, or even examples of conversations where you've had this, beautiful dialogue back and forth, an example of shared decision-making?
I think it's important that patients know what doctors are used to and what they're really good at. And what we've been doing for years up until the internet had good medically accurate information, because at one point it could be dismissed because it was all kind of ridiculous. But now it's starting to get better and better. It's really starting to hone down. Does not always get it right. And it's very important that you talk to a provider with experience why we should or should not do certain things, but to allow the provider to kind of ask the questions they're used to asking in the way that they ask them. What brought you in here today? If the answer is because I have blank, that makes the provider's job hard, because it's like, okay, well, I understand you're concerned about that, but what symptoms do you have? We need to know symptoms. We need to know signs. Did you notice a discoloration somewhere in your body? Did you smell like this weird smell? There are so many things that in our head help us to create that long list of potential diagnoses called the differential diagnosis, which you mentioned earlier. And we start to cross off things in our own brain and say, oh no, we need to test for this, 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 this. And again, you can approach it however you want to approach, but it is helpful if you know in your brain what you're concerned about, but you approach it from just answering the doctor's questions, because again, those questions help us hone down on what is or what isn't going on. And then once, the doctor gets to the place where you can tell they're kind of already formulating a plan, et cetera, very important that you do say what you think it is and maybe what you read, and say, I'm really concerned about this. If you say, I'm concerned about this, if any doctor is like dismissive of that, then same thing, man, you need a new doctor. But if you say, it is this, if you say that my problem is this, then we're kind of creating this environment when this is a group, project. This is a group project. We both want you to get better, and we want you to get better as efficiently, and effectively as possible. So to be able to keep it open from both sides, from the doctor better be open to having that discussion, and to have that openness from the patient is so, so important. I'm concerned about this. Perfect wording. They'll be like, okay, cool. Yes, that's something that I've been thinking about since you walked in the door. Actually, here's why I don't think this is, or here's why I think you might be right. That might be it. Let's go ahead and test this. Or my favorite is, I wasn't sure if I wanted to do this test or this imaging or not until you said that. And since you're worried about it, that makes me more worried about it. So let's absolutely do that test,
It's so significant, especially how I'm going to back up a little bit, how you mentioned, sharing what symptoms you have. I talk about really laying it out in a way that is clear, concise, and confident. My 3 C's.
Oh,
And
that's right. I
so
love
when
that. Yeah. Clear, concise, and
nice and
confident. It's
confident.
so
And
good.
so, for example, if you have chest pain, you say, I have chest pain for 3 days. It's getting worse. It's affecting
Yes.
my ability to get out of bed. And so that helps, like we talked about, that differential diagnosis that we have in our head to really put things at the priority. None of us can prepare for when we may end up in the ER. And God forbid that happens. But if there was like your go-to bag, your go-to things to prepare, maybe there's someone who is a caregiver listening right now or who has a chronic illness. And unfortunately, they end up in the ER often. What are the essentials that you would recommend to have ready before you go to the ER?
First and most important thing, bring your phone, bring a charger, because you're going to be bored. You're going to be bored. There's no way around that. Unless you get to be in the hallway and like see the action. And then you're like, I kind of like this, or if you don't like the gore, then maybe you won't like it. But so very important that you come with the phone charger and a phone. Always good to come with someone that you love and that you trust, to be there to help you advocate, to help you understand what the doctors and nurses are communicating, because again, sometimes we're in there and we may get too rushed. We may be like, I have this and this to do. I'm going to deliver this news real quick, and then I'm going to go over here and do this thing. And then I need to do this position and that. It's good to have somebody else in the room to ask questions, and please feel free to ask questions. So important that the patient and the family member understand what's going on and why we're doing the things that we're doing. So I think a family member is a great thing to bring with you. Also, you're bored, so better to spend it with somebody that is spend time with somebody that you care about, right? Unfortunately, don't bring food when you're bored. And also, maybe you're trying to console yourself with feeling pain or emotionally distressed or something. You probably want to eat, but there are many procedures where it's actually dangerous to eat and drink before those procedures. So it's important that you don't bring food and you don't bring water or caffeinated drinks or sugar, whatever, because you need to have an empty stomach in case there needs to be, God forbid, a significant procedure.
Well, speaking of food, both of us are parents, so I know when I say this, you're going to relate. Snacks are like the huge thing in my household. Snacks, snacks, snacks everywhere. My kids are always asking. So imagine you are a mom or a dad, which you are, and you have to unfortunately take your child to the ER. And I opened the show with talking about a child who has a high fever. And the reason why I did that is I had a case recently where a parent told me she was afraid to give her child Tylenol because she had been basically told that her child didn't even have a fever the last time she went to an urgent care and was pretty much dismissed, like, how, well, your child doesn't have a fever right now. So she purposely withheld taking Tylenol because she wanted to prove that her child had Tylenol. So in a scenario like that, first, we'll talk about, snacks and food and how you
Sure.
even navigate that as you're bringing your child to the ER. But what are your thoughts on that?
Well, I'm going to side with that patient. There is something about, not me personally, but in general, when you see on the computer screen the fever that's above 100.4, there's absolutely no question, versus when people say that there was a fever at home and maybe Tylenol was or was not given, and it's not documented, there is still a little bit of doubt in the provider's mind. Was there a fever? Was there not? And here's why. Not all methods of testing temperature are equal. There are some that you kind of scan along the head. You can't really trust those as much. Even sometimes the ones that go under the tongue, in the mouth, just like we all remember when we were a kid, some of those are really cheap and they're not very accurate. And so the only way for the provider to truly know that there is a fever above 100.4 is for them to actually see it. And I'm not saying you should always withhold Tylenol or ibuprofen before you go see the physician. But if that fever did spike up very recently, and you're about to leave the house to go there, not if it's going to be 4 hours, but if you're just about to leave the house, there's a fever, there is actually some merit to having the doctors see that that is a true fever. And there are other doctors who probably get mad at me for saying that. But I think that there is merit to that, honestly, because at that point, there's no question in your brain. Was the thermometer not reading that correctly? Did they actually, and again, we don't assume that anybody is lying to us ever, but a very important concept in medicine is trust but verify. If somebody says to you, this person has a potassium of 8, I'm going to say, oh my gosh, that potassium is so high, but I am not going to order the medicines that are going to bring that potassium down until I personally go look at the computer and I know for sure. I see the number 8 right there next to the potassium on the chemistry panel on my computer, and that it's a trust but verify thing. And it's actually how we keep people safer. But that same approach of trusting but then verifying is, you can't really do that with a fever. You trust them and yes, they probably had a fever, but what if they didn't? I don't really know for sure. But when you see it right there and you have the objective data there, it's verified,
I think this conversation helps because you mentioned, every doctor is different. There's something to be said about autonomy, and how we practice allows us to kind of approach patients differently. And I think the onus is on us as well to make sure that people have information, as you mentioned, about the different ways to check your child's temperature and how it can skew the numbers. And so as I was listening to you, I'm like, what if we could just make sure more parents knew about the different levels of checking it? Because they should be believed immediately. If a parent comes to me and says, my child has a temperature, I don't want you to withhold that Tylenol. But in our current world of trust and verify, which I do agree with you when it comes to like a potassium, a certain level, you don't want to do harm. Like that's what we go by. And so you want to make sure before you give any medication. But when it comes to certain situations, we've got to be mindful that we trust our patient in front of us, and how can we help them feel like they can advocate for themselves. Like, yes, my child has a fever, is by letting them know all the tools that are available, how it can skew those results, and still advocate.
And I also want to clarify that I never meant that like people should be dismissed that come like without a fever because you got Tylenol or ibuprofen before. I want to clarify that. I think you should absolutely, you take that into account for sure, and you believe them that they had a fever. But at the same time, again, there's something different in our minds when we physically see that number.
I agree. And I love that you shared the bias, because the bias exists. And so to pretend that it doesn't is huge, because as much as we want to say, this shouldn't happen, the real world is it can happen, where, to your point, if that doctor doesn't see that objective data, they may not believe you. So what can you do is so important. Quick note from the editing room. As you heard Dr. JMack and I discuss, all thermometers are not created equal. Here's what you need to know as a parent. The gold standard for babies and young children is a rectal thermometer. It gives the most accurate reading and is what most medical professionals still recommend for young ones. In fact, the American Academy of Pediatrics recommends rectal thermometers from birth up to the age 3. If rectal thermometer isn't an option, a digital forehead thermometer is a solid second choice, and it works for all ages. But please keep in mind, it typically reads a few degrees cooler than the actual temperature. Ear thermometers are also a fast and reliable choice, but are not recommended for infants under the age of 6 months because of their ear canal size. One thing to definitely avoid is forehead strip thermometers. They measure skin temperature, not body temperature, and are significantly less accurate. And no matter which thermometer you use, when you report the fever to your medical team, always tell them what type of thermometer you use and where you took the reading. A rectal temperature of 100.4 and a forehead temperature of 100.4 are not the same thing. And that detail helps you and your doctor better understand what's going on with your child. Let's jump back into the conversation. What are your thoughts when it comes to you have a disagreement with a patient? How do you navigate that? And what are some of the lessons that you've learned that even somebody listening who's a patient can take from that, or even some of the wins of where you were coming from?
I think the most important thing that you can do as a provider approaching that situation is to not take things personally. If a patient disagrees with you and wants to take a different route or doesn't want to test or does want to test, et cetera, there are some providers out there that would be very offended by that. But I think it's important for us as providers to see that, to recognize that there's a disagreement there and have a conversation. Because again, this is a two-way street. This is a bi-directional relationship. This should always be a conversation. And at the end of the day, it's like customer's always right. Patient is always in control. Patient is always in control. So if I think that a patient should have something and they don't, I just want to make sure that they understand where I'm coming from. So if I'm doing a good job as a provider, I'm describing the very serious condition that I'm trying to rule out and why the stakes are so high. And we absolutely need to rule this out if we want to ensure that you're going to wake up tomorrow. My job is to convey how serious this could be and how this test is going to make sure that that's not the situation or whatever it may be. And if the patient truly understands that and says, I hear you, but I don't want that test, then it's my job as a provider to say, okay, that's your decision to make. And so, I think honestly, it just comes down to communications. That is my approach, is just to do my very best to make sure they understand why I very deeply want to get this test, so we can all feel much more comfortable about what's going on or what may or may not be happening. And as long as I've communicated that effectively, then their decision is their decision. And if I don't respect that, I'm not being a good doctor.
And it all comes down to, I love how you said, don't take it personal, because I've had conversations with doctors who get really angry and they do take it personal. And in the end, it is about the patient, and the patient has the right to decide what they want. It's not about us, it's about them. And as long as you've done everything you can to communicate and share why you are recommending something, you have to kind of let it go and realize that as long as you've done everything you can, you're doing everything in the best way possible by letting it be about the patient and not about you.
Yeah, totally. And we almost should change the name when we order stuff. They're orders. They're orders. But really, they should be recommendations. Those are once they go in the computer, yes, they are orders. They're orders. We need to, make this thing happen for this patient. But at first, as you're having that discussion with the patient, those should be recommendations.
Oh, that's a beautiful idea. I love that. Well, Dr. JMack, this has been such a valuable conversation. I appreciate you. I appreciate you as a friend, all the things. And I love how you demystify the emergency room and really help people have practical tools to navigate the emergency care with confidence. I know everyone listening is now going to feel more prepared and empowered when they go to the emergency room. And hopefully they don't have to, but if they do, it will help. For those who want to learn more about Dr. JMack, you can find him on IG and TikTok. He shares healthcare insights with over 1 million followers. We'll have all the links in our show notes. Dr. JMack, are there any final thoughts you'd like to share?
Yes, follow me, follow my advice, whatever, online. Follow Bayo. She is such an incredible, well-informed educator. You're going to learn so much from her.
Thank you. I appreciate you so much. Well, we started today with the late night chest pain and the child with a fever, two situations that can make anyone panic in the middle of the night. What this conversation has shown is that when people understand how the ER works, they can walk in more confident, ask better questions, and ultimately get better care. And from my perspective, in urgent care and family medicine, I see how this type of conversation can help people feel more reassured and knowing what to do if they face a similar situation. Did something in this episode change how you think about emergency care? Share it with someone who might be anxious about seeking emergency treatment or navigating the healthcare system. Because here's the truth. Whether it's urgent care, primary care, the ER, these systems exist to help you when you need it most. Understanding how to use them effectively isn't only about getting better care. It's about advocating for yourself, reducing anxiety, and knowing you can handle whatever health challenges come your way. You've got this.
You got this.
Woohoo! Thanks for listening to Beyond Clinical Walls. If you learned something new today, please leave us a review on Apple Podcasts or Spotify. It really helps us reach more people who could benefit from these insights too. Hit subscribe so you never miss an episode. We've got amazing content coming, including great episodes with the health creators you love.
You've heard the truth, now take the lead. Stand for yourself, know what you need. One step closer, you've made your mark. Keep showing up and light the spark.